Testing. Good morning. Can you hear me?
Yeah. Good morning.
Oh,
morning.
thank you. Thank you for responding. Good afternoon.
Hi, good morning, everyone.
Good morning.
So today is our last presentation, yeah? Am I right? We still have
Yes.
this
Last
the last one,
presentation.
right?
Yes, correct.
How many of you submitted your manuscript? I know only one reported to me that submitted. Anyone else?
I
Not yet.
Submitted. Okay.
I submitted. Yeah.
Okay. Please submit on time, yeah? Late submission, then you have to go for supplementary. Okay, that's the rule, yeah? So make sure that your supervisor have seen your final copy of your manuscript before the submission. If let's say your supervisor haven't checked or not approved your submission, then you can't actually submit the manuscript, yeah? Okay, so please pay attention on this. Okay.
Okay. After
this
the
is a
submission,
one by one.
What means supplementary?
That means you don't submit, then I have to give you another deadline. So your exam final mark will be announced later, not together with your other subject. But your viva will be as planned. But your manuscript submission and then your it will be delayed lah. The exam result won't be the same as others.
I see. But the viva will be together lah.
That one need to check, because if let's say we have to decide on the supplementary date, the submission date first, then have to give the examiner the time. So if let's say it fits into this, then okay lah. Kalau tak, then they will have a separate viva. Wait first lah. Still got 2 days, right? 3 days. If got late submission, then I have to think about supplementary lah, because I'm expecting this batch no supplementary lah.
But the time at the KAMU is slightly early, like sometimes it's like you put last time we tried lah. I mean your deadline is 29. and then when we submit on 29, their state is late.
No, it's okay.
It's okay.
You're still allowed to submit. If let's say you cannot submit, you let me know. You
Okay.
still can submit because your submission time I can see.
Oh,
I can
okay.
even if it's late early I can see your submission date and time. So from there only it will be determined whether it's late or early.
After we submit, then the examiner will mark and go through. Then we
No.
chance. We still have chance to edit and what, right? No.
Yeah.
Yeah.
After the submission, will be I will check in identific your plagiarism and all that. If let's say it's more than 20%, okay, then I will ask you to correct it lah. I'll give you 1 week time, okay, or a few days, okay. Then after that, once we already get everyone's thesis check with plagiarism and all that, then I will give it to the examiner. So the examiner will be given time for them to mark, okay. Then after Viva only they will be giving the corrections to you. So then you do correction lah. Then I will give another deadline for you to submit your final manuscript. So that manuscript is the one that we're going to compile together.
Okay.
That will be the final one lah. Okay.
Miss Indira, can you help to do the checking first? Since we already submit.
I have to wait until Friday. Don't worry. Chill. I will
chill.
give time for everything. Okay. No rush, nothing. Your Viva is like very long. We have plenty of time. So you don't worry about this. Okay. You just make sure that you submit on time. Things will go smoothly for you. I won't rush anything for you. Okay.
Okay. Yeah.
Okay.
Thank you.
Okay. So Pepper, who's presenting? Kevin, Benjamin, Singwoon, and Sarin. Okay. Are you ready?
Yes.
Okay. So the final case discussion, yeah, today? Okay, you may
Yes.
start. Okay, once you're ready, you may start.
Okay, right. So, team, are you ready?
Yes.
Yes, okay. We move on.
Yes.
All right. So, okay, good morning, Miss Indira, and good morning to everyone. And this is today low vision case discussion, which is the last section. Okay. This session is a little bit lengthy, so everyone try to be a little bit patient with us, okay, because this case is very unique and there's more to discuss. Okay, next. Okay, patient name is CKH. He is a male, 5 years old, student, all right, and basically he have no OKU cards. First visit to SEGI. Next. Now, the first visit actually is 13 April 2023. And he was actually referred by Dr. Sundra with 4 identical diagnoses, which is already confirmed. One is hyperterrorism. Number 2 is mycotamia. Number 3 is persistent papillary membrane and with a small retinal colomboma in left eye. Now, the reason that he visited our clinic in low visions is to look for a good device, low vision device for study in primary school. And for that, he also planned to go for the specialty school, with low numbers of pupil, student in the class, right? And the parents basically knew about his condition since he was born, and he have basically regular consultations with the genetics doctor at HKL, okay, yearly to follow up. Next. So we go into the observations, okay? As a low visions, I think the record did put the observation on the kids, okay? So let's say, okay, observation. He have a good, ear structure. Nose is basically a bit narrow, with a NASA bridge. So not very sure what is that mean. Mean is that maybe the nose is very flat, okay? His ring fingers and little finger actually merged together and on the left hand, and microcornea. So I think this is a microtamia. Okay, so eye spacing between two eyes wide. So this can be hyperterrorism. Okay, and good coordination hands. I think good coordination means maybe it's a hand and leg movement and everything is good coordinations. Abnormal high forehead, chin length is normal. No trip lips, okay, and present with the epicenter fold, okay, where that is actually related to the so-called the white orbit, the white PD. Okay, he have a little bit of nystagmus, magnitude reduced when looking at the moving fan. Basically, he like to look at the fan. Okay, and that time the observation basically maybe can take note about the new point. Okay, and he have a big tongue, big toes. Okay, used to write letter in mirror writing form. So I am not sure about this term. And correct in writing means that maybe he only recognize capital letter and fail in smaller capital letter, and the patient don't know smaller capital letter. So this is an observation from the team, okay, that observed. Next. Okay, come to the ocular history. He followed up with Dr. Sundar 6 months ago, and then he didn't mention much about his vision progressions. Both of the eye visions is bad since was born, and the visual perception should be about 3 meter, right? And he have a nystagmus since born because become lesser, but still have a manifest nystagmus, especially when it's just from bright light to dim light. So the magnitude of the nystagmus become larger. So perhaps we can a little bit know more about the classification of the manifest or lanterns nystagmus type, pendular or jet, or where is the new point. Good to know that. And prescribed glasses 2 years ago from Thomson Hospital in use in school, but not helpful. Not helpful means there is a question mark whether it's blur, double vision, not comfortable, cosmetic reason, we don't know, right? So right eye vision better than the left, not much improvement with or without glasses. Means that is that glasses really doesn't help with what reasons? This one we have to find out. Now, dark adaptation problem, feel fear in dark environment and can't navigate properly. Is it not familiar with the place, or is it really the visual problem that caused him fear in dark? So this one had to go into medical history later. So he went to MBA to get a low vision device and suggest the telescope for the distance, but haven't tried it. We also don't know what is the reason why he don't use a telescope, and is it cosmetic? So a very interesting thing is that patient care about his cosmetic issue for the low vision device. So we know that roughly is a cosmetic issue. Okay, maybe he can see, he can still utilize his residual vision, but he cosmetically he feel a bit shy or whatsoever. So try to search for internet the click on smart. So meaning that it's very quite the navigation of the history. We know that it's a cosmetic reason. Okay, next we go for the next page. So this some medical history. Okay, no family history, no family history for this disease. Okay, he is only kids. So this term also I'm not very familiar. Okay, no heart issue. Okay, this one no epileptics. And then has asthma. Okay, so this one we take note. Okay, skin issue, yes, eczema, we take note. Dental issue, yes, we take note on that. Okay, so no hearing problem, muscle stiffness, patient left ring fingers, this one, okay, take note. Neuro problem, okay, so neuro problem, for what reason neuro problem is like soft hair, thin hair, skin grow, eyebrow, bladder control is no problem. That's why he can move around quite well, have some speech issue, okay, maybe it's a bit lacking on the, but finally, there's no mental development issue. Means that these kids are quite normal in terms of mental. So we had to go forward again to see what is the history. Next. So in a medical aspects, if patient undergo medications like inhaler and topical cream, so is it prescribed by the doctors or who? And then is a cream contains some steroid, okay? And how often the patients experience eczema and flare-ups, all right? So this one is not that critical, but it's good to know. Next. Okay, task history. So we know the medical.
Okay, sorry,
aspect.
Kevin.
Yep.
Okay, this is task-related history for this patient.
Yep. Okay,
Okay,
sorry.
he is, yeah, he's attending. You want to continue?
No, it's okay.
Okay, he is attending preschool. Total number of 20 students in one class. Teacher will sit with him and write a large size by using the small board. He knew letter with no speech delay. No problem in making friends in school, but start feeling himself had the differences with other students. He has no problem moving in familiar place, but no confidence in new place due to the vision not clear. Used to use normal pen to write, but in very close distance. He had no problem in daily activity and able to do all things independently. No color vision problems. He had difficulty in recognizing faces. Next. Okay, this is an additional information in task-related history. To include general observation during history taking is helpful. Is there any eye contact when history taking? How is walk and look at things? Is he wearing glasses? Comment any unique action throughout history taking. Did he have fall experience before? If had, how many times? How he move around in new place? Need caregiver? Why use normal pen to write but not pencil? How close is the distance for him to write? In what distance that he can't recognizing people face correctly? Question about glare is missing. Next. Okay, this is the patient visual assessment. Subjective reflection, right side plus 100, left side plus 175. RS carried out at Thompson Hospital last 2 weeks ago. Decent aided VA using lead symbol at 3 meter. Right side 1.22 logMAR equal to VA 6/100. Left side 1.22 logMAR, VA equal to 6/100. And both eye 1.10 logMAR, VA equal to 6/7.75.5. Near aided VA, both eye 1.6 m at 5 centimeter equal to N12. And we found that right side and left side not perform VWP. Next, please. Okay, PD of this patient is 46 and 45 near mm, cornea diameter 5 mm, keratometer or topography not performed, color vision not performed, color test, autophoria at distance with mild nystagmus, moderate XP with fast recovery at near with nystagmus. EOM difficult with lateral gaze. Okay. Cornea diameter 5 mm, right, we don't know right or left. And the pupil size is right or left 5 mm. Intercanthus distance, not mentioned. Nystagmus classification, null point, observation or need to do in next consultation, and centric view training needed or not. Not mentioned the severity of nystagmus for near vision. Next, please. Visual field test not performed, E-scan not performed, tonometry not performed, OCT not performed also, and slit lamp examination, right side iris coloboma, but we don't know right or left, or this is new findings. And left side is unable to detect due to patient not cooperate. And fundoscopy unable to detect due to the patient not cooperate too. And right side not mention which part of the coloboma located, superiorly, inferiorly, nasally, or temporally. Next, please. Okay, the management of this patient is no new RX were prescribed. Non-optical management, 6B pencil was suggested to use when he need to write. Large font size when reading was recommended. Thick line paper feature extra bold. Dark line, space wider apart to improve visibility, and ease writing were recommended. it was recommended that a referral letter to be submitted to the school to support the request for longer examination hours and extended homework deadlines. And it also suggests patients consider applying for an OKU card to facilitate access to appropriate support and benefits. TCA 6 months to monitor vision, task-related problem, and low vision device selection. Next, please.
Okay, come to discussions. Basically, we like to share with you about the cases. Next. So, number one, hyperterrorism. So this is basically a congenital craniofacial deformity. Okay, and it's characteristic by the very far apart between the orbit of the two eyes. And this incident basically is only one in 1,000 live birth. And there is some study that there's a very high prevalence that strabismus will come in, and also with the exotropia. And then, of course, they will come in with refractive errors, okay, with this kind of with the parents that is with the high refractive errors. So this kind of condition will happen. And for that also, basically, the anomaly, okay, is like the cliff-lifting syndrome, also can impact the ocular functions. Okay, next page. So for these particular conditions, okay, we can actually try to relate to telecanthus, epicanthus, and blepharophimosis. Okay, these are all look almost alike, and that is this chart is actually differentiate the diagnosis that you can actually know. So like the hyperterrorism, the features is eye that set apart, the orbit actually set apart. Okay, telecanthus is inner corners, the medial canthus is far apart. Epicanthus is a skin fold covering the inner corner of the eye. And then blepharophimosis is actually small and narrow eye opening like ptosis, So basically, I have already mentioned about these orbits and the key clues that you can see by this chart. Okay, right. So next.
Yeah, next I will continue about condition with microphthalmia. Microphthalmia actually is when one or both of a baby's eyes are small. Both conditions are rare and can cause vision loss or blindness. Actually, they can occur in isolation or as part of a syndrome with a complex etiology involving genetic and environment factor. Genetic cause include mutation in genes such as XOX2, OPX2, PAX6, and CHX10. About the clinical features is include high hyperopia, reduced axial range, and papillomacular folds. They will include choroblastoma, cataract, and retina detachment are common ocular complications. There are no treatment that can create a new eyes or bring back visions for people born with anophthalmia or microphthalmia. Next. Here is a differential between a microphthalmia and an anophthalmia. So from the definition, microphthalmia is abnormally small eyes. Anophthalmia is a complete absence of eye. Here we also listed some about the growth of orbits and about the imaging of OCT or MRI. So the vision is a main concern that microphthalmia actually may have limited vision on the mild case. But for anophthalmia, there were no vision in always blind. Next. So we go through also about persistent pupillary membrane (PPM). So PPM is a congenital condition where remains of fetal membrane persists across the pupil. So the natural cause is about usually regresses spontaneous during infancy. They may persist into later life if regression is incomplete. So about the clinical impact, they are often asymptomatic extensive PPM can obstruct the vision axis and lead to amblyopia. Can complicate cataract surgery also. About the vision outcome, some patients with significant PPM maintain good vision acuity due to the pinhole effect from multiple small aperture. About the management for PPM, normally conservative management is generally preferred. Surgical removal considered if dense membrane occur. Next, thanks. Now we look to the small retina chorobama for the patient for the left eye. Retina chorobama is a congenital eye disorder caused by incomplete closure of the optic fissure during embryonic development. So the structural effect can involve different parts of the eyes and often lead to vision impairment. This is due to the strong genetic basic. It's more than 40 genetic loci linked to the condition. About the prognosis, despite surgical advance, vision outcome often remain limited due to complexity of condition. A complication about for retina coloboma, they were related to retina detachment, which is 29.4% of cases, choroidal neovascularization, 13.7% of cases, higher risk of retina detachment when the coloboma evacuation is deeper. Management for retina coloboma. For a retina detachment, the pulse prima vitrectomy plus silicone oil tamponia, 81.2% success in the reattachment. Second is choroidal neovascularization. Go through the laser photocalculation or intravitreal pivesioma. Thank you. The next one. So this one we try to make a timeline of ocular and craniofacial anomalies development about our patient. So we believe that hyperterorism is a very early craniofacial development between week 4 to week 8. And then we come with microphthalmia, early eye ground issue within week 4 to week 10. The third one is a small retina coloboma, fairer closure of optic fissure within weeks 5 to 7. And lastly is persistent pupillary membrane PPM, appear later in fetal life, may persist after birth if it fails to regress. Normally it's on month 5 to 8 gestation, persists into infancy. Next. Okay, now we look to some discussion about this case. So we purposely to put out this statement from the history just now. Patient care about the cosmetic issue for the low vision divide. So yeah, we understand that parents of course they are very emotional and everything on their children's happen. So of course we have to open a conversation with the parents. We have to lead the patient, and as our optometry, I think we need to let the parents understand about her son condition. We have to let parents know about low vision actually is a reduced vision acuity that cannot be corrected with glasses, contact lens, or other medical treatment. And important, we have to let the patient understand the childhood vision impairment can lead to delay motor, language, emotional, social, and cognitive development, all of which can have lifelong effect. Low vision rehab should begin early as a parallel, ongoing treatment modality, not as a last resort when all other medical approved if fail. So actually our patient, their vision is still good on now. So we have to find some way to help. Actually, and we also didn't know about the progression of the vision for this child. As long as now he still have N12, if I'm not mistaken, just now for the reading. So we can see how to help and how to help the parents to go through the low vision divide Okay, next. So about the patient care, yeah, again, patient care about cosmetic issue for the low vision device. So of course, first we have to open the conversation. We have to validate their feeling. We have to know, actually every person, yeah, different. Every person will have their unique. It's perfectly normal to notice you look different when you're using a device. Let's find something you feel good about. This is we try to bring out is optometrist what we can do the best for the patient. So actually, we can ask what the broader about the low vision device is about the size, the color, visibility, and where he most like to blend in. So about we can also try a range of aids for the patient, like pocket magnifier that can track easily into a pocket or sleeve. Wearable electronic magnifier can be recommended. iPad to enlarge fonts or fashion forward frames, like the phone case, like the iPad case, or smartphone-based app also can be recommend for the patient. Handheld video magnifier with swappable, colorful screen cover also can be recommended for the patient, or when the patient really go to the low vision device. Next. Customize for co-factor about the low vision device. Offer the frame color option like I just now already told, right? Sorry, bright pattern or minimalize that match his personal style. Add a fun sticker or silicone sleeve to handheld aided aids so that look like a gadget, not a medical device. Let him pick an accessory like the lanyard, cases, strap that feel more like sport or teach gear. And of course, we have to build confidence throughout the training. Teach him to display and show the device quickly and confidence so it feels like second nature. Role play real world scenario, reading menu boards, textbooks, so he sees that peers won't bet on eyes. Share success story or short video of other children using similar aids. Involve parents in celebrating device success. Post look what I can do now on I mean this is like a home-based scenario, or we can sharing with the parent. We can do like that on the fish or on the boards. Then the parents have to take part to encourage the children's. Next. So actually the second one is just now the history taking there is mentioned about no problem in making friends in school, but start feeling himself have the difference with other students. Yeah, so this is a very sad question, of course, for patient and for his family. But we have to most positive thinking and help on the patient and the parents. First of all, I think we really need to validate and normalize the emotion. Reassure them that everyone has a unique things about them. Confidence building, create a superpower wall at home, poster of their top skill, hobbies, and proud moments. Encourage patients like art, coding, music, sports, so friendship from around share interest is but not just about vision. Give me a second. Okay, so celebrate daily wins, like let's say the children can read the page, mastering a scooter trick with a quick retros, we can give a high five, or we can give a sticker for the patient. This is the way we encourage the children's what they are facing now. So second. Next, this one I just now talking about is more to the vision rehab. Beside we how to help the patient vision, this is I think is the most important part on this case for this case. Yeah, thank you. So I pass to my team.
Okay, so I will cover this part. So there are some they are supporting children with ocular and facial anomalies. So okay, as a family and caregiver support, right? Okay, so they are playing a crucial role. Okay, so family and caregiver, right? They will ensure to have a regular eye checkup and follow up. Okay, and then encourage. This is the family and caregiver that's supposed to do. Okay, so family can encourage patients to use of spectacles or low vision aids, and create a safe home environments such as good lighting, remove hazards, and then besides that, family and caregiver also have to like provide emotional support and build self-confidence. Okay, for this kind of patients, and then parents also should learn about the conditions to set realistic expectations. So beside that, school and teacher also playing a very important role, such as such as a teacher may provide front or side seating in class for best visions, and then use large print, magnifier, or digital tools for this kind of patients, and ensure good classroom lighting and reduce glaring. And then foster inclusive peer support, prevent bullying. And the next one will be implement individual education plans if the patient is needed. So the next one, and beside this, as a community and public, also playing a crucial role as well. So community can promote like awareness and acceptance of children with eye anomalies. And it also like make public spaces accessibility, such as lighting, contrast, marking, safe playgrounds. And then it also, as a community, also may support advocacy for vision screening and low vision services. And then it also, like as a community, also may encourage support groups for family as well. So the next one will be healthcare and early support. Okay, as ophthalmology, from the ophthalmology or optometry part, okay, we can help for this case monitor PPM, coloboma, and microphthalmia. And then for the low vision rehabilitations, okay, is to help to maximize the remaining visions. And then the next one will be can provide genetic counseling as well, such as advise families on inheritance. And then the next one will be psychological counseling to support mental health and self-esteem. Right. So there are two key organizations in Malaysia actually. We have Malaysian Rare Disorder Society, and the next one will be National Council for the Blind Malaysia, NCBM. So okay, so we just go a little bit more about this society, MRDS. So actually, start from the beginning. I also not really know about this society. So actually, who they are? It is a voluntary organization in Malaysia supporting people with rare disorders and their families. So it is founded, officially registered in 2007, started by parents and healthcare professionals. So normally what they will do, they will provide emotional support and connect families with others facing similar challenges. And they will organize events, talks, workshops, and outing for awareness and community support as well. Publish resources, example, they have a rare journeys of love book to share story and informations. And to raise, through this, right, it may help to raise public awareness of rare conditions through campaigns and rare disease day as well. So the advocacy, right, okay, it is a work to improve healthcare access and treatment for rare disease patients, to push for better social acceptance and inclusions of families with rare disorders. So why it is matters? It is to help families feel less isolated, provides resources, and connects them with a support network. So actually for this case, patient maybe can think about to join this society. Okay. So next, we go for the National Council for the Blind Malaysia, which is NCBM. So who they are? it is an umbrella body founded in 1986 that coordinates organizations serving the blind and visually impaired in Malaysia. So normally they will provide education and rehabilitation support for the visually impaired, offer Braille transcription services through the Malaysian Braille Press, support vocational training and employment opportunities, and also advocates for policy and rights for blind and low vision people. So the member organizations, right? So it have several. That day that we visited one, and MAB is also one of the member under this NCBM. Okay, then the next one will be Society of the Blind in Malaysia, St. Nicholas Home in Penang, Sabah Society for the Blind in Kota Kinabalu, and Sarawak Society for the Blind in Kuching. And then, okay, it is important to helps to ensure equal access to education, training, and resources. And it also will help to promote some independence and inclusions for the blind community. The next one will be provides a national platform for collaborations and advocacy. So this is their websites from the National Council for the Blind. Okay, so if you're free, then maybe you all can search for it. Then you will know more better. So for the conclusions, okay, children can thrive with family, school, community, and healthcare support. So early intervention plus inclusive environment, so it might cause patients will have a better quality of life. So the public's role, right, will have 4A. The first one will be awareness, second, acceptance, accessibility, and advocacy. So okay, and then so when the child asks why he's different, and the most important thing is to listen with empathy, explain in simple and positive terms, and to reassure him that differences do not define his worth. So by highlighting his strengths, right, promoting inclusion and connecting him with supportive environments, we can help him to build their confidence, resilience, and a positive sense of identity. So these are all our references for this case. All right. Thank you.
Hi, thank you for the very long presentation, but detailed one. Okay, I like the part where you have discussed on how to handle this patient who is actually having concern on his cosmetic appearance when he uses the low vision devices. Okay, that's a good point to be discussed. Number two is about the association of the rare disease here. Okay, I heard about it, but thank you for the detailed information about that. Okay, I heard about it, but I have no idea. I've never worked with them. Okay, thank you for that information also.
Actually, they
Okay.
have a manual, like for the rare disorders. So
The
I think these
definitions, is
patients,
it?
yeah, they have one manual. So maybe can refer to this website. Yeah, so I have go through some. So for the facial malfunction and all that also, which is included in the manual.
Okay, okay. Thank you, Sari. Okay. Okay, while you were actually, you know, I mean, this is group C, right? Okay, while you were actually looking at the case, right? Did anyone has the idea that this patient might have some syndrome? That's why he's having like multiple complication in, no, in the eye. Have anyone of you thought of that? Or you think that he has like a 3-4 separate, you know, problems that leads to this? Anyone? None of you? My question is, do you think this patient have some medical condition that lead him to have like, you know, multiple complications in his eye and also his physical appearance? Have anyone thought that he might have some syndrome? Like Down syndrome, you know, there are many syndromes, right? Okay, do you think that this patient has some syndrome, or you think that he had it like a different complication, that's all?
I think have lah, since it's due to gene.
Mm-hmm. Okay, okay, when you have this kind of doubt, right? When patient, okay, like this one, Dr. Sundar referred to us, so we know lah what's his problem. Okay, I know. Okay, but if let's say a patient comes into your clinic with multiple complication like this, okay, first of all, you have to find out what is the syndrome that this patient could have. Okay, and then once you already know, I'm just giving you tips on how to handle patients, yeah, with multiple complication. Okay, if you see there is something is not okay, if let's say a common one like Down syndrome, you know, okay, they will have like a, you know, a specific appearance. If let's say patient is having albinism, you know what kind of features, when you look at them, you know that this patient is having albinism and this patient is having Down syndrome. Or if let's say patient even like autism kids also, after you interact them, you know, after like 5-10 minutes you spend with them, you already know that this patient is having autism. Okay, so there is a specific features of the face physical appearance and the way they speak, their eye contact, that makes us to know, you know, whether this patient is having this kind of syndrome. Okay, when a patient comes in with multiple problems, okay, and you think that this patient is not normal, something rare, okay, so what you could do with this kind of patient? Okay, number one, first of all, list down all the problems that you think that the patient is having. Okay, like for example, you know that this patient is having microphthalmia based on your observation, got a few things, right? That is number one. Number two, the patient is also having like, you know, the fingers are, you know, attached together, fused together. Okay, put in all this information. Now we have Chat GPT, we have Gemini. So we have many things. You just can put in that and you can ask, you know, I have a patient who comes in with this kind of problem. What could be the syndrome that the patient has? Based on that, it will suggest you like the patient might have this syndrome A, B, C, because this is rare disease, you know. Like if let's say Down syndrome, you when you see, you know already. So that one you no need to ask, you know, Google for it. But if let's say this kind of rare syndrome, this is what you have to do. Okay, when you see patients in future, your customers come in with multiple complication, especially kids. Okay, with, you know, nose bridge is very small, eyes are flat, but you know it's not like something very common. Then you have to Google for it. Why is it important? Okay, why do we need to know what syndrome the patient is having? Okay, when you know the syndrome that the patient is having, it will be easier for you to know what is the core problem of this patient. And when you know the core problem, then for you to actually do the assessment and also, you know, only do the assessment that necessary for the patient, because patient is a kid, attention span is very small. Okay, so you have to actually plan your assessment. You cannot just simply throw all the assessment or do visual field, do OCT, do, you know, A scan, everything. No, based on the syndrome, you know what is the problem of the patient that patient possibly could have. Plan your assessment according to that, and then when you give management also, it should actually, you know, fits you know, all the condition that the patient is having, answering all. It's not like, you know, microphthalmia, you do this. Okay, then the patient is having the small nose bridge, you do something else. No, that's not how you handle the case. Okay. Okay, okay, management wise, the discussion wise is very good. Okay, out of the box, something very new. Okay, but what is the core thing that you miss in the case discussion is the patient is actually having one syndrome. Okay, and the syndrome's name is ODD, oculodento, oculodento, what is that? Wait, I've written just now while you're talking, I looked back at Dr. Sundar's referral paper. Wait,
Oculodentodigital
digital
dysplasia.
dysplasia. Yes, ODDD.
Yeah.
Okay. So this is the syndrome that the kid is having. Even if you look at the history taking, right? Can you go to the history taking slide?
Yeah, sure.
Yeah.
Okay, the first slide. I think the second slide. Third.
Oculodentodigital
The fourth one.
dysplasia.
The fourth one. Yes, correct. Okay, if you see here, We don't write this much of history taking for many people. Most of the cases that you have seen, right? We don't do this. Okay, why do we have to write about, the chin length is normal? Okay, no cleft lip. Because we know that this patient is having ODD. First of all, I ask the students to write down what are the uh, signs of this patient. So based on that list, I ask them to observe the patient, ask the parents whether the patient is having this or not, and then put a like a checklist, or the patient is not having this but he's having this. Okay, so that is the reason why we have so many information on this. Okay, so this is how you handle this kind of case. If let's say you think that it's not a common disease, something very unique, you take the information based on your observation. Okay, and then based on the history taking, you get the rough idea. This is the reason why we write down a differential diagnosis in the beginning. Okay, initial differential diagnosis. So based on that, you will have idea, and then you may have like 2 3 initial differential diagnosis. So when you do assessment, you rule out, oh, number one is not that, because he doesn't have this, the findings, or the mother say he doesn't have this particular problem, so he cannot be belonging to the first disease. So you have another two only. So another two is easier. Okay, then you do one more test, then you can rule out another one also. So left with one. So that will give you idea of what actually the problem of the patient. Then from there you take over. Okay. Okay.
Very
Okay.
good.
Now for the assignment is we're going to discuss the same boy's case. Okay, but now from a different angle. Now you already know what is the problem of the kid. Okay, ODD. Yeah. Okay, what I want you to do is, okay, you divide. No need to be only group C. You all divide among yourself, 13 of you. Okay. Based on the ODD and the findings and the management, how your perspective change. Okay, if now you already know how you're going to present the case with this ODD perspective. That's what I want you to discuss for today's discussion, because this is very interesting case. Okay, can we do that? Because you have you have the case, but now your case is going to take another perspective. Okay, just now you presented the symptoms all asing. Now, when you know the patient is having ODD, your case presentation is going to be different. Okay, so maybe one group can do on the assessment and findings, another group can focus on the management. Up to you. You all divide yourself. Can we do that? No one, is it? No answer?
Okay.
Okay.
Okay, yeah? Okay.
Okay.
So I will see you again at 10:50 with the same case discussion from a different perspective, from the ODD's perspective. This is a syndrome that the patient is having. Can we? Can I?
Okay.
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 Okay. So 10:50.
Thank you.
Okay.
呃，怎么跑不进去了？Hello，
Hello，
说什么？怎么不见了呢？
假爸爸，
Hello hello，
假巴假巴，
八了就八了。
你今日也有精神哦，你爱读个了了哦，
啊？
你爱读了了 slide 哦。
是你说啊，是不是这个东西？你选的 case，
到底是
做东西知道吗？其实，
我们的主是找做他的新根嘛，对吧？
嗯
好像没有什么东西这样。
，but then，这只是我的建议啦，就是说，如果这是一个兵找他的东西和他的 management 的话，如果放在同一个 PowerPoint 的话，下次大家也可以容易 refer 回啦。
就是全部人放在用同一个 PowerPoint，
啊，
就
我们可以
一直做
分开，
前面发。
我们可以分开，我们可以分开 A 的做 A 的，B 的去做 management，只是我们放在同一个 PowerPoint slide，so that 改天大家可以 refer 回这个病的时候，我们也会懂啦。for revision 也好，for
大家用
改天的，
同一个 link 哦，大家用同一个 link
是，只是我们分 Group A 跟 Group B 的工作啦，这样子好吗？
OK 吗？
意见。
Hello Group B，
会有个要求，就是在 PPT 里面哦，那些 terms 啊，可以附加一个照片。就我看到那个 ODD facial 那边，yeah，it's very good，but 好像有些我们讲的那个什么 microcornea 啊、microphthalmia 啊那些，我觉得这些我们再附加一个明显的照片，说点我们会更明白到底所谓的大小眼是怎么样的大小眼啊，怎么样才算大小眼，然后等等的东西啊。
OK，我加照片，我加照片。
我现在在找的，不用紧，然后那些如果还没有东西做的，或者没有什么其他 information 的，可以 start going through 那些照片哦，因为我觉得更 precisely 有照片会更明白，原来我们看到这样子 system 后会直接 lead 这样的东西。 Kevin 啊，我的意思是说，不需要重复的，只是like 一个 guideline where example 我们如果看到有这样子的 symptoms，so 我们要做些什么东西，就是 like you know maybe history taking to clarify 一些东西，or 有没有一些 medication 的 justification on 这个 symptoms and so on 啊，just a quick guideline。So 如果我们看到这样的情况，我们不会 panic 嘛，我们应该要做什么？要 check VA，要做什么东西的？So just as 一个 guideline for based on optometry 上。
Okay, understood.
这个不会是那个 management 吗？for 另外一个 group 的 side。
It's okay， 我不知道他们会不会有 discover 到，但因为其实我们讨论到这东西，我们要怎么样去证明他是这个 symptom， 所以有些人他不知道，他没有去看医生 ，maybe 有些人他 overlook 了这个，原来是一个 symptom 来的，所以我们 as a optometrist 如果我们看到的话，可能我就当他不知道，我们就要 refer 他可能要去做这个什么 genetic test 啊，还是怎么样的东西啦，就是一个 quick guideline， 我们看到这个情况，我们应该要怎么样？要验眼呢，还是要什么那样的东西啦？ 事实上已经是搞定了，那些 slide 已经安排了，对不对？前面1、2、3、3连4、5、6。
OK，
4、5、6、4、5其实是照片了，应该要解释更多了，好不好？Picture A、B、C 这个是什么东西哦？然后6、7、8其实是看起来是一样了，就是也要看哦，所以要 OK 这个4、5、6、7、8、9，3个、4个、5个，6个人嘛，对不对？
边有
6个人。
我在那边有 orange 啊。
是吧？谁不能 join presentation？Alex 不能啊，我说。Jennifer，
我在这边
我们在
哇
WhatsApp 那边，我们在 WhatsApp 那边已经分好那个 slide 了，阿瑞你去看一下。
有 Vicky 姐了。
好 ，OK，good，then 可以了。也不要试下，应该不需要吧，都可以了。OK，我们搞定了。Q 一下，淋一下 copy，我们11:50了，对不对？是的，4:50了，这么 Miss 还没有回来，text 他一下，不然的话我们12点还没有结束。
Hi, sorry for the delay. Shall we start?
Yeah, can.
Sure.
So we can start.
Yeah.
Okay. Good morning, Miss Indira and everyone. So today our case discussion topic: ocular dental digital dysplasia (ODDD) syndrome. Our group A member Kim Sun, Chen Yong Hao, Lau Yun Xiang, Lim Chiong, Am Hai Ting, Se Yan Chen, and me, Tam Bi Yan. So the definition for the ocular dental digital dysplasia is a rare genetic multi-syndrome disorder. It is the name after the major feature. Ocular is mean eye abnormalities. Dental is the mean dental anomaly. Digital is the finger malformation. The genetic causative gene is the GJA1 gene mutation, which encode connexin 43, a protein essential for the gap junction communication. Inheritance pattern, most cases is a autosomal dominant. Rare cases is autosomal recessive. The prevalence in the world, extremely rare, estimate lower than 1 in 10 million people worldwide. Only several hundred cases reported. So what is the autosomal dominant and the recessive? The dominant one is just a copy of the mutation is enough to cause the disease. If one parent has the mutation, each child have a 50% chance of getting the disease. The pattern usually show up in every generation, means there is a vertical inheritance. The recessive is mean you need 2 copies of the mutation, one from each parent to get the disease. If you only have 1 copy, you are a carrier, healthy but can pass it on. If both parents are carriers, 25% of the child get the disease, 50% child is a healthy carrier, 25% child is completely healthy. It means that this pattern can skip generation. The parent is healthy, but the child suddenly has disease. So I pass to my team member.
Okay, so this is the ODDD facial dysmorphism. So from the photo A, we can see the eye feature, and A and C, you can see the eye feature, and the B and D, we can see the fingers abnormal. Next slide. Yeah, so left side A, B, C is showing that the finger and the bones bones abnormality, and the figure A here we can see one eye is smaller and bigger. So even though the aperture size is the same, but the eye showing difference at the vertical, and this is a finger. It also one of the abnormality. Next slide. So the clinical feature, so this is what we call microphthalmia and the optic nerve hypoxia. So for the ocular feature, so microcornea means the small cornea. Microphthalmia means the abnormally small eyes. Congenital or early onset of glaucoma, which is a major cause of vision loss in ODD. So the optic nerve hypoxia or dysplasia is occur in ODD, and the cataract will occur in some cases. So the progressive of visual impairment due to the glaucoma or optic nerve defect is one of the fungus finding in the patient's ODD. Next.
So next is me. So for the clinical features for dentals, it will be microdontia, small and peg-shaped teeth, enamel hypoplasia, thin or underdeveloped enamel. So delayed eruption, teeth may be emerged later than expected. Increased caries risk due to enamel defects. Hypodontia, missing teeth, but this is really less common. Abnormal morphology is something like the lower down right side here. The root will be like getting like different normal size. Next. Can we next it? The next one will be the digital features. So basically will be syndactyly. So it's which mean webbing of finger, especially 4th and 5th digits. So camptodactyly, permanent flexion of fingers. So splenodactyly, curvature of fingers. Branchdactyly, shorten of digits. Nail dysplasia, thin or brittle or malformation nails. Toe anomalies, similar changes may occur in toes. So next. And this is other systemic features. So the photo was showing the skin will be like the palmar or plantar hyperkeratosis, which means the thickened skin on palm and soles. Beside that, the hair and will be like very thin, sparse, slow growing hairs, and the skeletal will be occasional cranial bone anomalies. So I will pass it to my team members.
Okay, so how to differentiate the physical trait in optometry practice? So we observe the general appearance for the face feature, observe craniofacial morphology, look for the symptom clue like hypertelosia, abnormal eye distance, microprestis, and underside joint, and facial asymmetry. Not skin, hair, and nail abnormality. This may hint at ectrodoma, dysplasia, or connective tissue disorder. Assess symptom symmetry and proportion. Disproportion this feature may suggest genetic syndrome, example Marfan's and Down syndrome. Ocular side. Anterior segment abnormality, use the CLAM to detect the microcornea, iris hypopsia, or strawberry line displacement. Termination for discriminant nerve membrane where cornea ends and anterior chamber angle begins. Posterior segment clue. Fundus exam may relieve optic nerve plasia, retina detached, retina pigment change. Functional sign, reduced acuity, myxedema or strabismus can be symptomatic mark. Hand and digit, impacts of synthetic, chronodactic, branchiated. These are classified in ODDD and another syndrome. Check the nail morphology, thin, british, and dysplastic nails may support a diagnosis. Plan joint mobility, hyperflexibility for shrinkness, and incandidate connective tissue disorder. Next.
Okay, the fourth one is the dental crew. Okay, so we can observe on the visual inspections, like microdontia, the previous already said, the enamel hypoplasia or abnormal erosion pattern. Okay, pattern is very normally will frequent cavities, delayed erosions, or orthodontic issues. So in the discipline referral is collaborate with dental professional for radiographic confirmation. The fifth one is the neurological and systemic group. Ask about the motor milestones. Delay or spasticity may point to CNS involvement. So screen for hearing loss is conductive deafness is common in ODDD. So it also reveals family history, autosomal or dominance pattern can guide differential diagnosis. Next.
Look into as an optometrist how we're going to handle this kind of scenario when we're facing the symptoms at above. First, don't be panicked. We will need to be a recognition and initial assessment. So first look at the appearance. As we mentioned, all the symptoms were listed earlier, such as ocular, dental, digital anomalies. So history taking is very important, such as how's the vision complaints and family history about the eye, dental anomalies, and also systemic features. So ocular exam, so we can do a VA check. Is this possible if it's grow enough, a big kids, and also assess on the amblyopia and whatever status on the eyes. So last one, also observe on the binocular vision. So whether the patient has a strabismus, any amblyopia, that it's actually lead to a problem of a development the eye. Okay. Second, we are ongoing optometrist care. Like, if possible, we try to go through even deeper, knowing how's the refractive status. Prescribe a spectacle to manage the ametropia, because while they are still developing, so the optimize of the power and the eyesight is very important. So of course, the other one, low vision, if it's we encounter that there are difficulty on looking at something, so we will assess on the low vision support, such as introduce a magnifier and also high contrast material. And most of the less, if it's possible, we will probably also need to prepare a recommendation letter for school purpose. So apart from that, we also need to have monitor regularly on ocular health, such as if it's having this cataract and IOP related, we need to regular check on the symptom and also refractive status. The third one, we will referral to other multidisciplinary collaboration, like Chi Yang mentioned earlier. So such as ophthalmologists for the glaucoma and cataract, if a surgical intervention is needed. So dentists as missing teeth and enamel defects. Geneticists, if they are not even diagnosed of any like ODD before. So it is good that discover more whether there is any underlying or hidden syndrome that we have not discovered. So the last one, a psychologist or any NGO buddies, because the social interaction, as mentioned, the kids we discussed earlier. So he felt that he is something different than the normal people. So that is also affecting the growing of the process. So the mentality support, the encouragement, and the counseling, it is also very important to the kids like him. So the last one, as an optometrist, we can also educate and monitor as below, explain the condition of ODD symptoms. So we will go through how it's a risk and progressions on his vision. Sorry for the typo. So at least both party, parents, patient, and we optometrists, we are understanding, we are working through this. Interdisciplinary care, not just like mentioned, optometrists, we are also hands in hands with other professionals. And the last one, if it's possible, we will try our best to provide support. Like in the earliest, our peers will present the organization. There's a rare disease support group, so that see into it, what are the helps and things that they can help on this child and the patients. Next. Yeah, so we are working out this survey form, so while we are doing this, so we won't be lost tracking on how we justify this ODD patient. So first we were looking at this chip complaint, whether they have this blur vision, photophobia, difficult on that. So by ruling out all these symptoms, so that will lead you to the final diagnosis. So this is the clearest picture how we can link every symptoms that we saw in the clinic, like the past ocular history, whether they have any surgical intervention before, long-standing refractive error, binocular vision, history of parents' illness, refractive history, and family ocular history as well. So this is the guideline for, as an optometrist, what we can do as what we can. Okay, and last one. And thank you very much. If you are not knowing about your eye condition, so this is the call button for everybody. So please look into it. Visit us at the Sengi Eye Clinic today to get a thorough eye examination, to knowing how's your eye status, because we provide wide range of the examination. A binocular vision, we have contact lenses fitting management, and also a low vision assessment and management. So yeah, just call us if you need us. Thank you.
Okay, thank you for the presentation. Other groups are presenting too.
They are more covering on management. At first, we proposed that we try to
Okay.
merge, but there's no response on that. So I foresee that they have another presentation on booking.
Okay, okay, thank you for a very thorough presentation, yeah, on how to actually, doing assessment and also, observing ODD patients here. Not only ODD, but rare cases, okay, rare ocular condition or rare diseases. This is how we have to do it, okay, and also you mentioned that, the physical traits that you need to observe. Do you need to do on all patients? Obviously, no lah. Okay, we don't do it on all patients. When patient come in, we do the normal general observation first. So when you do the general observation, you find the patient is normal, just having, like glare problem, or having some shaky hands. That is quite normal. Okay, but if let's say patient comes in with different features, okay, you feel like this patient is not like a normal kid, something else, okay, then you have to do the observation more. Okay, you have to look at, but obviously you can't, you have mentioned that the dental, the teeth has to be observed. Obviously you can't open your mouth and do the observation, but while they're talking, if let's say you're speaking to the parents, right, maybe you can ask, is there any features that is different, in your baby that you think it's like, different, in terms of the, dental features, is it different or not? So you can ask that, okay, rather than you observe yourself, because they're not dentists, they're not allowed to do that. Okay, maybe you can ask about that, is there anything that you observe different in terms of, the fingers, that we didn't notice yet? So they might tell you. Okay, only if you find that this patient is different, even when you look at this boy, right? When he came to our clinic, his feature itself, looked different. When he come in, he looked different from others. So when he's different, right, we will be curious to know what could be the problem. So you start observing him, while doing assessment, while talking to him, or while talking to the parents. Try to get as much information that you could, so that you can actually compile all that and actually diagnose the patient, so that your assessment and management will be more towards that, ocular condition that the patient is having. Okay, so we don't do it to all patients, but customized according to the need. Okay, and I like the form that you showed just now, the previous slide. Yes. Okay, you okay, the history taking method that I have mentioned is that I taught you is the foundation. Okay, but with that foundation you can actually have your own history taking method, okay, or a flow that you can utilize, so that when you see more patients, right, maybe with the 9 you get only the basics. Okay, if let's say patient is like having like rare diseases, right, you can have your own history taking template, okay, that you can utilize, like particularly like this, okay, for you to actually do the history taking, so that more information can be received. So whatever that I taught you is just a basic or foundation. Okay, you can develop more than that. So as how you have actually came out with this history taking, from I think you got it from somewhere, right? So you can do it. Okay, so I think it's a very good presentation and everybody understands what is ODD. Okay, so now we can move on to the assessment and management. The other group, are you ready? No response?
Yes.
Ready, yeah? Okay. You may present. Okay.
Okay, so basically, Group A have mentioned much of the cases, and just a brief one. Okay, our team's Group B. All right, this 5 years old child have features consistent of the ODD, which is ocular dental digital dysplasia, a rare genetics syndrome involve the eye, denture, and also digit, which is fingers. Now, as an optometrist, our role is not only to refract and prescribe lenses, but also to provide long-term low vision care, support learning, and also work in a multidisciplinary team. Now, so next page, okay? This page, correct. So firstly, we must perform a comprehensive low vision assessment. The child actually present with the microthymia, coloboma, and also nystagmus, all which is limit to the visual potential. We need to establish a best corrected visual acuity for both distant and near. Now, assess the contrast sensitivity, come back, sensitivity and visual field, since the coloboma may cause localized scotoma. Observe the nystagmus null point. In this case, the child nystagmus reduces when looking at the moving fence, which indicate that the functional null points should record. Next. Benjamin. Okay. Benjamin. Okay, in terms of the low vision aids for near tasks, okay, hand and stem magnifier, dome magnifier, even electronic devices such as tablets with zoom and high contrast function may be introduced. For distant, telescope system could be considered if vision permits, though practically in a 5 years old must be evaluated. In the classroom, large print book, bowline exercise paper, or preferential sitting near to the board are essential, and also proper task lighting and to minimizing the glare, okay, can be significantly improve the vision function. Next.
Visual function and low vision care. In patients with nystagmus, the primary focus of low vision care is to optimize the visual function through tailored interventions. Low vision's comprehensive assessment should include best corrected visual acuity, contrast sensitivity, fixation stability, and binocular vision status. Low vision aids such as magnifier, telescope, electronic device can enhance reading and distant vision tasks. Proper lighting, high contrast material, and task-specific adaptations also play an important role in improving quality of life. Early referral for low vision specialists is important. Advice of posture consideration and referral. Patient and caregiver, including teachers, should be advised that slightly abnormal head posture is acceptable if it provides a meaningful improvement in vision and does not cause musculoskeletal strain. In such cases, it is better to encourage its adaptation rather than force the patient into a normal head position that reduces visual efficiency. However, when the head posture is excessive or causes functional issue, referral for vision correction or surgical evaluations should be considered. Clear guidance on when to escalate to this intervention ensure that management remains patient-centered, balancing functional vision benefit with long-term comfort and health. Next, please.
Next we go on the refractive and ocular management. So for the first is microcornea or micro-ophthalmia. And then next is a careful psychopelagic refraction, often for the high hyperope or astigmatism. And next is early correction to prevent amblyopia and to support the visual development. As for the coloboma, regular dilated fundus check to monitor the retinal breaks or detachment. And then next is to educate parents, urgent review if flashes, floaters, or visual field loss. As for the persistent pupillary membrane, PPM, so usually benign is not obstructing visual axis, but check for the amblyogenic effect. And lastly is consider referral if the VA is limitation due to dense PPM. Next.
Okay, next we're talking about the disciplinary collaboration. I think just now group also is already touching a bit about to manage the ODDD patient. We as optometrists we still need to cooperation with other specialized like pediatric ophthalmology. Because patient is having a retina choroblastoma, though the retina monitor is crucial to to prevent possible glaucoma risks and low vision rehab, vision therapies, early interventions, orientation and mobility training if needed. So dentist also, you check for the anemia, hypoplasia, missing teeth, also a part of the feature of the OTTD, and the genetic pediatricians yearly systemic follow-up, and also about occupational therapy or teachers support in classroom, letter orientation issue like the BDPQ, just confusion about our patient is more confusion is this kind of words thing. Yeah, for next.
Okay, so the next one will be parental and school guidance. Okay, and then there are like educations for parents, such as like condition is genetic, and then must have a regular follow-up is lifelong, and then encourage stimulation with tactile and auditory learning. And then parents also must be patient with letter orientations confusions, not only visual, also neurodevelopmental. And then for the school recommendation, right? So we prefer smaller class size and low student teachers ratio, which is already planned. And then it also like may provide accessible materials such as large print and digital. And then beside this, teachers also like to understand no point and sitting arrangement. And then the last one will be allow extra time for visual tasks. So like for this kind of patients, maybe like teachers will give more extra times for them to complete their visual tasks, their task lah. Okay, so next. So for monitoring and long-term planning, for the visual development, we can have a frequent review, such as like every 6 to 12 months. And then for the psychosocial, right? Okay, it is to access self-esteem, social interactions, such as appearance differences plus functional vision loss can impact. And then the last one will be vocational planning, which is for later. So can advise on realistic expectations, encourage skills that do not depend on fine stereotypes. So next, I will pass to Mike.
Okay, this is our optometrist rule in ODDD summary. Early reflection correction to reduce amblyopia risk. Second, low vision rehabilitation. Low vision aids, lighting, classroom adaptation. Monitor ocular abnormalities like glaucoma, microcornea, and PPM. There's a persistent pupillary membrane. And document and support nystagmus, null point, coordinate interdisciplinary care, ophthalmologists, genetic, dental, OT, and teachers. Education, parent, and teacher for long-term adaptations. This is our end of presentation. Thank you.
Okay, thank you. Thank you for that. Okay, now the management looks more wholesome. Okay, because the diagnosis is identified and that actually is your management. Okay, so somehow you have corrected your earlier presentation. Okay, although no much changes, but when you are actually, doing the assessment and management, right? When you know the diagnosis, you know you're doing it right, rather than you are assuming that this could help, okay, or this can be done, okay, this can be attempted. So the assumption is lesser when you know the diagnosis lah. Okay, so that's the core idea of this. And thank you for this group, group C, right? Group B. Group C lah just now. Okay, for presenting this. Okay, now I have one question and I need everyone's opinion. Okay, this patient's concern about cosmetic appearance, although it's already discussed, but I want to know your opinion on this before we end this session. Okay, this is a five. How old was the kid? 7 or 5?
5.
5-year-old kid. Okay, this 5-year-old kid is actually, have some concern about his cosmetic appearance. If let's say you uses, any devices, or generally he's having that. He doesn't want to look different. Okay, and do we convince the patient to still use the devices or to do, some training? Okay, because we want the visual development to happen, or we tolerate his concern on his look or cosmetic appearance. What's your opinion on this? The last discussion before we end.
As we learning from Dr. Fu article, we should not like
compromise.
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 Mm-hmm.
We cannot pressure the patient to accept that lah. But we can do the best to convince him and hand by hand to lead him to more the way. But because we know the patient using the low vision device is definitely help for the development. But the choice is up to them lah. This is my opinion lah.
Okay, anybody has a different opinion than Chingwoon? It's okay. It's a discussion. You can say that no. It is necessary to convince the parents and the patient to use this. Anybody have such opinion? Looking at the age of 5, we don't want him to be amblyopic, already have so many defects. We don't want the vision also, get worse because, the patient is giving concern on cosmetic appearance. Anybody has that opinion?
We already know that this case that the devices is very important for him. But if he do not want to accept it, actually it's very subjective for us now, whether we can put full concentration or not, that to get him back to the practice, to be familiarized with us, to build the trust and show that our empathy that we want to help this child. So we need to get the parents so-called like the corporations to bring the kids more often back to the practice. And then we also had to spend a lot more time to have interaction with the kids so that to make him feel that this is a second normal to him. Right. So this is my thought lah, because it's not easy, but I think it's very much depend on the individual practitioner whether have the time to do it.
What's their concern more? Whether it's
Yes.
the vision or the the kid concern.
Yeah.
Okay.
So also our hard effort lah.
Anybody else have a different opinion on this?
My opinion is because the child is still young, important to counseling him the benefit of preventing him from being a low vision. Because if you got low vision, also if he has lazy eyes, going to be impact his future life. It's important to as counseling him from time to time, train him to use low devices, and also the how to explain to him his real condition and benefit of using all these devices. Important also. We cannot say we respect him, then we don't teach him, then in the future he will suffer. No? Rather let him suffer right now, rather than suffer in the future.
Okay, that's a good point. Anybody else?
Same like Stephen say, because patient actually 5 years old, I think that we jangan paksa dia lah. But we can actually 5 years old, is it possible to introduce this patient to like go to MB MBB that can recognize some age similar like her to like make friends first, and after that maybe this patient will be realized that not just her got this problem, so we'll be willing to try to learning like group same with low vision patient lah. So, and about the cosmetic problem, just now I searched the Google. Some of this patient when elder, they went to the aesthetic surgery. That's why I think that maybe can educate, maybe when in the future you still can go some aesthetic surgery lah. This is not a problem for her lah, because she's just 5 years old only.
Okay, that's a new perspective, yeah. Okay, good. Any other opinion?
Yeah.
Okay. Yeah, you
sorry.
go first, Jim.
I just want to take out one of the point that's the management for age 6, and then just now like Jennifer said that for now it's age 5, the management is like that, but up to their grow up, the management is different already lah for this kind of special patient lah. That's all. Thank you.
For my side, I agree with what Kelvin said. Kevin said, well, as optometrists, we can build up the trust and rapport with the patient and parents. From time to time, we can see them, follow up with them, so that the convincing also easier, so the kids follow. And also like good point from Jennifer, also like can do the plastic surgery for their feature. But one thing I want to raise out is recently I received from my daughter, 13 years old. She say one of her classmates getting bullied just because of the frame is a light blue plastic. So the friend bully him, saying that he's look like a Down syndrome baby. So every day call him Down syndrome baby. Down syndrome. At first, the boy got friend. After that, no more friends. 13 years old. Normal children. So I mean the cosmetic appearance also very important for the children also lah. I mean have to consider also. Of course, Jennifer say we can bring the child to the same group, same disease, so that they can make friends and they can build up their confidence. But if go to the real world, real school, so the bullying case also there lah. Just a simple light blue frame getting bullied as a Down syndrome children also. Yeah. So I raised this to the class teacher also. That you must know about this case also. Thank you.
Okay. That's the how to say, that's the practicality of what's happening in the real world, yeah. Okay, that's a good perspective also. Another one. Okay. Anybody else got other opinions?
I just want to sort of conclude a little bit like for everybody words. So I quite agree on we have to have an encouragement for the kids of 5 to use of the this low vision aids, and pretty much he is concerned about the cosmetic, but we can make it both way instead of we're talking so many reasons behind what is the risk factor. So kids normally they don't understand so much on it. So I will suggest that more to compromise a little bit instead of encourage her keep using that very odd magnifying of things and stuff. We can sort of make it a bit of a modification, put up some nice blinking thingy on shows at how different on this this low vision device to encourage her to use it as a super tools to encourage her start using it lah. So it works both ways lah. Instead of keep on telling why you're not using it, how it helps with the eye. So at first we need to let the kids to accept it first. You're gonna slowly go by it. So it is really a challenge, but I know that it's gonna take time. You need to have more care and understanding and use a different way to distract them, just not paying attention on so much on just appearance. If yes, then what we can do to overcome that appearance. So that's what I want to cover on it. Thank you.
Okay. Thank you, Ray, for concluding based on your understanding. Yeah. Okay. So basically how to handle this, because this cosmetic appearance, this bully case is quite common, yeah, and visually impaired person, especially kids, they're getting bullied. Okay, so they do get bullied if, let's say, they are wearing, even like Vicky said, even a light blue frame also, it's a matter. Okay, and imagine if, let's say, that kid is actually wearing a thick lenses, with a magnified eye can be seen through the frames. Okay, or thicker lenses. These are all actually a factor that is in there when we want to actually prescribe them or when we advise them to use, right? All these have to be taken into consideration. Not everyone in the circle is going to be accepting the fact that, okay, they are special. Okay, they might be in the worst circle where they are actually, even if, let's say, you have like a one person different from others, they are going to be looked at, or treated different. Okay, and the treatment, if, let's say, it's a good treatment, obviously, the patient is going to be accepting it. But if, let's say, the treatment is going to be, the other way around, right? It's going to be very traumatic for the patient, especially kids. Kids are very sensitive. And this kid, right, I think the mom told me that in the beginning, the kid wasn't, aware that, there is a difference in the body. But after reach a certain age, right, then already start questioning the parents. Why my fingers are like this? Why am I different from others? That itself, it's very difficult for parents to handle. Okay, so if, let's say, this kind of patient already, have the awareness that, they're different from others, and that difference can be something, a tool for a bully case in the, in the place that they are in, a school or, their neighborhood, anything. It has to be taken into consideration on how we manage this case. Okay, is there any protocol to handle this case? No. It based on your understanding about the about the patient's real life in the in the real life. Okay, you can say that, okay, visual development is important, so I'm going to convince the mother, I'm going to do this, I'm going to do that, I'm going to make things acceptable for the kid. It might be acceptable for the kid, okay, when you try that in the clinical environment. But when the kid is bringing that tool to the school, okay, it's going to be a subject of discussion to other people. Okay, so then comes the problem. Okay, so what we can do as a practitioner, in handling this kind of cases would be, okay, first, as how you all mentioned, okay, like, the group B in the initial slide also, you have already mentioned, to make the kid to be happy using it. Okay, if, let's say, the kid is happy using it, no issues with that, and they can use it only at home, no need to bring that to the school. If, let's say, they bring to school, they are not comfortable using it, so in school they can be given some other alternative which doesn't make them look different from others. Okay, so rather than we are forcing them to use all their item in the school, okay, whatever they can use in the house, they use it in the house. If, let's say, they are not ready to actually expose themselves being different by using this kind of tool, then don't do it at school. So that would be one of the options that we can give them. Another set of way of handling this case is like Jennifer said. If, let's say, the kid really need to have a visual development, okay, we really need to develop it now so that he doesn't suffer later, like Stephen said. Okay, if, let's say, this is an issue, then the future is also going to be another issue because there is no vision. Okay, or the vision is like very limitedly developed. So how to handle this case is, okay, if, let's say, you really know that, if you already diagnosed that this patient is actually low vision, okay, so if, let's say, using these tools or adapting to whatever management that we are giving, and patient doesn't want to do it because getting bullied in the school, then it's time for them to think about whether they want to still send them to the normal school or not, or they can have an option, go to bring them to a special school, or if, let's say, they have like good financial background, then they can go for this home school based, can be suggested to the parents. Okay, so that so that the parents know that this is a concern and you have to tell them the consequences of this. Okay, if let's say you don't develop the vision problem will be another additional problem in the future. Okay, but when you want to develop, there is a barriers or challenges, obstacles like bringing to school and using it, or doing it in the school is difficult. So they have to consider of, maybe can consider of changing school, so that the patient, at least the visual development happen first. And when they are ready to face the world, maybe in the secondary school, then they can be shifted to the normal school. If let's say the parents really want them to actually experience the real scenario of life, okay, maybe can consider after secondary school, once the vision development is actually, already optimum, then can go to the secondary school, to the normal school. And by the time, you know, they would actually, more confident, or, the vision is better, or, ready to face, then they can go for the normal, schools and all that. That can be also suggested. So there is a lot of things is involved here. Okay, obviously our priority as an optometrist is to make the vision, maximally develop before the plastic age is over. Okay, we can tell the parents, okay, when there is a concern about the cosmetic appearance, these are the things that you need to do. Okay, like making them very comfortable using it, number one. Okay, and using it at a private place where nobody sees can be done still. At least a few percentage of development still happen. Okay, if let's say kid is ready to bring to school, then they are okay. If let's say they're not ready, then use it only during the home task. So, and they have to accept the fact that in the school they're going to struggle. Okay, and if let's say the parents are okay, then we can advise them to actually, next option will be shifting school. Okay, or bringing them to a place where similar problem people are, in a group utilizing the same tools, so they wouldn't feel very weird. Okay, and wait for them until they are, they grow mature, get matured, and then put them back in the real world. Also can be done. So these are the options that you can have it in mind. Okay, the one that I'm giving you is based on our discussion. There's no protocol, okay, on how to handle this. This is based on what are the opinions that you have given us. So based on this, okay, so when you have patient in the future, right, and these are the concerns that the patient is having, so you can utilize, the idea that have been shared and see what is the best that suits to that particular patients that you're handling, and then provide that to the patient. Okay, rather than, you have your own, usually we will have our own idea on this or our own point on this. But what you have to do is think about whatever opinion that is being shared in the discussion, and look at the background of the kid, background of the school, background of the family, and see which one is the best to suit them. It's not like one protocol applicable to all. Okay, it can be the same cosmetic appearance, concern that the patient have, but different background, different lifestyle, need a different approach to handle it. Okay, I think that is what I want to share, based on this case discussion. Okay, I think okay, and this is our last case discussion. Yeah. Okay, thank you so much for all the case discussion. I think we had 14 cases, I think 14 or 12 cases. Okay, thank you so much for all the case discussion. I don't know how much you have learned from all this case discussion, but I learned a lot. Okay, it's very exciting, and as all the lecturers, even the clinical supervisors that have actually, supervised you said, okay, this batch, you can have a case discussion non-stop, even with a small one-word topic also, you can actually, discuss for 2 to 3 hours, because everybody is, very involved in giving opinion, not, taking back when I ask for opinion. So it's a very interesting, 14 weeks of discussion. And thank you so much for all the efforts, for all the time that you have actually, allocated, with your busy schedules, with other lectures, your own work, your shop and all that. But this is a very good session. I enjoyed it a lot. And also, Miss Geeta, told me every single week she'll be texting me. She said that this is the best batch that she have ever supervised for clinic. She told me that, the way you handle patients, it's very professional, and the way that you are discussing the case, the eagerness, the interest that you have to learn new things, right? It's very impressive. So she said this is the first batch that she have seen that have all in a group. Everybody's not like one person is better than the other one. So she said equally everyone is very interested. The way that you present the case, the way that you discuss the case is like, she's very impressed lah. Okay. But I told her that we have been seeing them for the past 5 semesters. So we are kind of very used to their enthusiasm. I think you're very new for it lah. Okay. So that's all for today, with the happy note that, we are done with our 14 weeks of case discussion. Okay, and we are almost done with the semester. And I think you travel the most with me this semester. Okay, mostly every week you will be seeing me. And it's I think we should end it with a good note lah. Okay, good things about you. So I thought of like, ending up with, the comments that I have received from Miss Geeta for this particular course. And I think that's all. Anything that you want to share before we end our last case discussion? No?
We learn a lot from you also.
Yeah, I learn a lot from your, every single, sometimes I have like, doubts and all that, right? Sometimes your discussion will give me answer. Oh, this is right. Okay, so it is always a fruitful discussion. None of the session was was flat or plain. Every time I learn something from you all. Okay, thank you for the.
We also want to thank you. Yeah, thank you for understanding us. Yeah,
Thank you, welcome.
busy schedules and all these things, and bear with us for our mistake. Yeah.
Okay, welcome. And you want to take a picture for our last session? Maybe you can take a picture. Last case discussion. Yes. After this, I'll be seeing you during exam, exam week. Practical exams. We do have practical exams. Okay. Okay. Stephen was here? Yes. Okay. One more. Xiong.
I think
Jerry.
they're handling customer.
Handling customer. Then, okay. Shall we take picture? Who's going to take? I take. Okay, I take 1, 2, smile. Okay, taken. Okay. Thank you so much. I'll send you the picture in the group, yeah?
Right. Thank you, Miss.
Okay, bye. See you all during the practical exam, yeah?
Thank you, Miss Indira.
Okay.
Thank you.
Bye-bye.
Thank you.
Bye.
Thank you. Bye.